Good. And we are recording.
Hi, everyone. Welcome to our seventh episode of Nashville General Hospital's Wellness Wednesday program. Thank you for joining us today. I'm Kathy Poole.
And I'm Kaylin Harris. Our goal of Wellness Wednesday is to introduce you to Nashville General Hospital experts, have them share information vital to your health and wellness, and give you the opportunity to ask questions during the presentation. In support of Asthma Awareness Month, today's guest is Dr. Richard Fremont, NGH's Chief of Internal Medicine.
Dr. Fremont is board certified in pulmonary medicine and critical care medicine. He is an associate professor of medicine and serves as chair of internal medicine at Meharry Medical College. Dr. Fremont treats conditions such as asthma and chronic obstructive pulmonary disease, or COPD. Today, Dr. Fremont will share information on asthma, common complaints, potential triggers, and how it relates to COVID-19. If you have any questions, please feel free to comment below. Welcome, Dr. Fremont.
Thank you, Kathy and Kaylin. So I'm going to talk a little bit today about asthma, which is a very common disease that I see. And I've prepared a few slides for you to discuss this disease. So moving on, asthma is a chronic obstructive lung disease. So what does that mean? It means that patients have inflammation in their lungs that causes a tightening or a closing of the airways. The hallmark of asthma, though, is that it's reversible. And so patients who get these symptoms, you can reverse them with medicines and they get better. The symptoms also don't happen every day all the time. Another hallmark of asthma is that there are triggers that cause the symptoms to happen. Now, asthma is very different from emphysema because emphysema is not reversible and it causes chronic lung damage, while asthma is reversible and can be controlled. So why do people get asthma? There is definitely a family history component of asthma or genetic component. It's not fully understood at this point. A lot of patients have allergy symptoms or atopy that is associated with asthma. So it's not uncommon to see somebody who has bad allergies and associated asthma. Potentially, smoking when a woman is pregnant can increase the likelihood that the child has asthma, and exposure to tobacco as a child can also increase the likelihood of asthma. Now, interestingly, childhood asthma, which is relatively common, can go away. And so you can, quote unquote, outgrow it, and then you don't have it as an adult. Or you could outgrow it and then it could recur later on in life as an adult. And then very rarely someone can develop asthma as an adult who never had it as a child. But this is very, very unlikely. And a lot of times it's a misdiagnosis. I think we went the wrong way on the slides. There we go. So this is some statistics about asthma, which should concern everybody. Close to 10% of the US population is affected, and that's 300 million people worldwide. So it's a common disease, a common childhood disease. In the US alone, over 500,000 hospitalizations are occurring to asthma. And 2 million ER visits per year. So it's a tremendous burden on the healthcare system. Unfortunately, about 5,000 people per year die of asthma. And this is bad because this is a controllable disease that if patients know what to do, have medicines with them, they should not die. And then from a financial standpoint, $14 billion per year are spent trying to control, fix, and deal with asthma as a burden. So this is a slide that I wanted to show looking from 2001 to 2017. And really what this is showing us is that the rate of death, which was higher back in 2001, 2002, 2003, it's kind of plateaued. So with all the technologies and all the good things that we can do in the last 15 years, the mortality rate, the number of deaths per year for asthma is kind of stagnated. And we're kind of stuck at that 8 to 10% rate, or about 3 to 4,000, 5,000 people per year dying. Next, please. Oh, I think we're stuck on our slide here. We've been having technical difficulties all day. Okay, so I'll just continue a little bit while we're working on those slides. So asthma is a disease that, as I mentioned, that's reversible, and it's also known to have triggers. So there are a lot of things that could make a person who has asthma get worse. Some of the things are pets, so dander, animal dander, strong noxious fumes or perfumes. I'll talk to patients who, they get in an elevator with somebody standing next to them who has perfume or cologne on, and that triggers an asthma exacerbation. Changes in temperature, hot or cold, are something that can trigger somebody's exacerbations. So I see a lot of people when the seasons change, they come in more short of breath than they were when the season was kind of in a steady state. Other things that we see a lot with asthma is patients wheeze. So one of the hallmarks of asthma is wheezing, which when you wheeze, what you're doing is you're exhaling and you're hearing air push out of your lungs, and it sounds like this squeaky noise. And really what that is that the airways themselves are narrowed or tight from all that inflammation, and you're actually hearing the air push out through the airways. And that's what wheezing is. And so wheezing itself is another hallmark of asthma. So reversibility, triggers, and then potentially having wheezing on a physical exam. So a patient who comes in with a good history of what I've just described, we make a diagnosis potentially of asthma from a history, from a physical, and there's some tests that we do. And then we start them on medicines. And the two major medicines that patients take are something called albuterol, which is a medicine to relax or open up the airways. And that's what we use as a rescue inhaler. So patients who are on albuterol, they usually carry around their albuterol inhaler with them and take 2 puffs when they start feeling short of breath. And so if an exacerbation is starting to occur, taking those 2 puffs of albuterol may stop it. The other medicine that is a hallmark of treatment for these types of patients is an inhaled steroid. And there's plenty of different names of them, but what they are is they are a controller medicine. So you would take it 1 or 2 times a day, and that is to reduce and prevent that inflammation from building up, and therefore patients don't have exacerbations. So a good controlled patient may be on a controller medicine and never have to use their rescue inhaler. And a patient who's not well controlled would have to use their rescue inhaler 4, 6, 12 times a day and is constantly short of breath. Okay, it looks like our slides came back. This is an old slide from about 20 years ago, but it's something I wanted to highlight because this hasn't gone away. There's clearly a mortality difference by ethnicity when it comes to asthma in the United States. And you can see from this slide that the Black and Puerto Rican population has a much higher death per million rate than other patient populations, the Caucasian population, even the Hispanic, Cuban American population. So this disease has adversely affected to a higher degree the Black and Puerto Rican population. And this is just a couple of quotes that from the US EPA, which is very disturbing. So Black children have nearly 2 times the rate of current asthma as a white child. So in other words, it's much more prevalent in the Black population. And then Black children are 2 times as likely to be hospitalized for their asthma and 4 times as likely to die as a white child with asthma. So a stark difference in ethnicity and populations for this disease. I've already mentioned some of this. So patients show up wheezing, dyspnea, that's a fancy term for shortness of breath, chest tightness, and coughing. And then some of these triggers, again, I've mentioned a few of these, like changes in temperature, GERD, which is heartburn, can do it, allergies, exercise, noxious fumes or smoke. So lots of things can potentially trigger, and most asthmatics know what their triggers are, which is another hallmark of the disease when you're trying to make the diagnosis. I thought it was useful to talk a little bit about COVID. So as of right now, we do not know of any association between asthma and COVID, in the sense that you're not more likely to catch COVID if you have asthma, and you're not more likely to do worse if you have asthma and catch COVID. Now, you could potentially do worse. We just don't know, that we have not made that association yet. So if you have COVID and asthma, we treat you just like you have COVID and you don't have asthma. As for getting vaccinated, everyone should get vaccinated. There's no good reason not to get vaccinated, and asthma is not on that list of reasons. So there is no reason not to get a vaccine if you have asthma. In fact, you should, because you already have a lung disease and you don't want a second one. Now, masks. I can definitely see some patients who think wearing a mask is interfering with their breathing, especially a bad asthmatic patient. And really the key there would be experimenting with different types of masks to find one that you can still breathe and not exacerbate your asthma with. And there are so many different types now that I don't think that will be a problem, but you should still be able to wear your mask with asthma, especially a cloth or a paper mask that's very thin, and it should not make your asthma worse. Okay, so this is something called the Global Initiative for Asthma, and it's basically, what do physicians and hospitals, what are we trying to do to our asthma patients for best practice? And what this means is that we do not want any daytime symptoms. So a well-controlled patient is not symptomatic during the day. They're not limited in their physical activity or their exercise. They're not waking up short of breath from their asthma. They're not having to use their rescue inhaler more than twice a week. And their lungs, when we measure them, have almost normal functions. And then last but not least, they're not getting exacerbated. So if all those things are happening, that's a well-controlled patient, and we as physicians and you guys as patients are both doing a great job on that individual case. And then I just put some down here. What are rescue inhalers? So these are some short-acting rescue inhalers. Albuterol being the top one. That's the one we use most frequently. It's not important, the other names there. And then this next slide is some steroids that we use. Maybe we can push over to the next slide. There we go. So these are some steroids, and again, there's a lot of different ones. It doesn't matter which one you use, doesn't matter which one your physician prescribes you. You just want to make sure you're using one of them every day to try to control your symptoms. And I think that's our last slide.
Well, thank you. Thank you so much, Dr. Fremont. You have provided some great information on asthma, and definitely have opened up my eyes to a lot of things I was not previously aware of.
Great.
And we did have some questions that came in before this session. So one of the questions is, do air purifiers really work?
So if you get a one of those FDA approved HEPA filters that does remove some stuff from the air, for a specific person, it could have a benefit, especially if they have a lot of allergies and dust triggers. If you're not triggered from your asthma from dust, it's unlikely that a purifier is going to make much difference, but there is definitely a subset of the population with asthma that an air purifier could help them.
Okay, perfect. And then see, you just discussed dust triggers and allergies. So what is the difference between allergies and asthma? Like if I currently have allergies, can it worsen to become a form of asthma, or what are those two separate entities?
So they are two separate entities, and there is an association. So some patients with asthma also have allergies, And so allergies are such like runny eyes or scratchy throat, pollen causing allergies for people who have it, sneezing, maybe some coughing. That has nothing to do with their asthma, but their asthma can also be triggered by something like pollen, and asthma is specific to the lungs themselves, while allergies can affect the entire body. So you can be a patient who has allergies who does not have asthma. You can be a patient who has asthma and without allergies, or you can have both. And we actually assume a lot of our patients with asthma do have an allergic component, and some of the medicines that we use treat both allergy and asthma.
Perfect. Thank you. Thank you for answering those questions.
You had mentioned global initiative for asthma.
Yes.
So if anyone has young children who are showing signs or been diagnosed with asthma, they shouldn't necessarily keep them out of sports, should they?
Actually, no. I mean, so there is even an exercise-induced asthma. There's a variant of asthma called exercise-induced, and that usually occurs about 10 minutes after you stop exercising. But it's very, very easy to treat. You just take your rescue inhaler before, and it doesn't limit you at all. So asthma should not limit sports, should not limit exercise when it's controlled. Now, if somebody is having severe symptoms and is not under control, then you're not going to want them to do a lot until they get under control. And if they're a really bad asthmatic, they need to see a specialist. But once they're under control and taking their medicines and not exacerbating, there's no reason why they should be limited at all.
Great news. And then what if you just happen to be with somebody? I mean, how can you tell someone's having an asthma attack? And then what should you do to help them?
Sure. So, acute or rapid shortness of breath is a very common sign for an asthma attack. So someone breathing fast, someone making audible sounds when they're breathing, which is that wheezing that you may hear. Most asthmatics know that they're having an asthma attack and would probably tell you. And so what you're really going to see is a rapid increase in breathing and shortness of breath. And what you should do, well, first, hopefully they have their rescue inhaler and can take a few puffs and get it under control, but you should call 911 and get some help for that person. There's not a lot a bystander can do for someone having a severe asthma attack except get them to treatment. And the longer an exacerbation occurs before treatment, the longer it takes to get them out of that exacerbation. So we want to try to get to them as early as possible and get them on medicines as fast as we can.
Thank you.
Sure. Any other questions I can answer? I think you're muted, Caitlin.
Yes, I think that is all the time we have for today. But thank you very much again, Dr. Fremont, for the informative presentation on asthma. And then additionally, if any of our viewers or viewers upcoming have any additional questions or need to see a pulmonologist, see, look, I'm working. Please call 615-341-4968 to schedule an appointment with Dr. Fremont. You may also visit our website at nashvillegeneral.org. Once again, that number to call is 615-341-4968.
Again, thank you, Dr. Fremont, for joining us today. And we appreciate everybody who has tuned in or will be tuning in later. Go ahead and mark your calendars for our next Wellness Wednesday event on May 19th at 12:15. We'll have Dr. Joseph Akama, NGH interventional cardiologist, as part of Stroke Awareness Month.
Can't wait to see everyone at that next session. Have a great day.